Good afternoon, everyone. This is Lynette Elliott. We appreciate you all joining us at the top of the hour for the Gravity Project meeting on today, August 15th, where we will be going through food insecurity data sets. We will go through a few administrative items first. For those of you who haven't joined the call before, this is something you will see very often if you visit us more than once. We do record these meetings, and we post the recordings and the meeting materials on our Confluence after the meeting. So we have everyone muted upon entry. There will be opportunities for you to ask questions and share information verbally, but in the meantime, during the meeting at any time, if you have questions or comments you'd like to pose, you can use the chat feature. It's down at the bottom of your screen, most likely. And if you send it to everyone, it gives all of us the chance to address it, including other members of the community. We've had some really good chats before, and we appreciate everyone who provides input when someone else has a question. If you have any technical difficulties or other questions or want to follow up with us following the meeting, you can email me, Lynette Elliott. My email address is lynette.elliott@emiadvisors.net. Next slide, please. If you haven't already done so, we invite you to join the Gravity Project, and I will point out in our announcements that these URLs have been updated. So we will, like I said, we will send out a follow-up email following this meeting. We use the distribution list of the join members, so if you have not joined the project, you will not receive emails from us. But we will include these updated URLs for all of you in that email. And if you want to check whether you've signed up or not, you can also check the Confluence. The member list is posted publicly. Next slide, please. Today, we will go through some announcements, very exciting announcements, I'm glad to say. Then Linda Hyde will walk you through data element submissions to date. She's got some statistics to share with you regarding those content submissions. And then Sarah DeSilvi will walk through a discussion of roles and interventions. And there will be time for all of you to ask questions and provide comments during that time. And then we will give a quick next steps at the end of the call like we usually do and send you all on your next meeting or the rest of your day. Our announcement today is that Gravity has a new Confluence URL and homepage. We have listed it here. And we wanted to make sure that you are all aware that we have moved that Confluence page to a new URL and a new web page on the HL7 Confluence space. And there is currently an HL7 website under development. So if you've bookmarked these pages previously, please make sure you make these updates once we send out the follow-up email and when we post these materials on Confluence. And we will share the website URL as soon as that goes live. The reason this is happening is that Gravity is now an official HL7 Fire Accelerator project, and we are so excited about this. For those of you who have followed us since our kickoff last May, you are aware that we've always intended to transition our work into the full suite of HL7 Fire work products. This doesn't change our current scope of work, and we are going to continue working toward our phase 1 goals and deliverables. What this does is support our official transition into the phase 2 work, which is, I'm sure, where a lot of your heads are already. So this is why we're so excited. For those of you who are not familiar with the HL7 Fire Accelerator program, it's designed to assist implementers across the healthcare spectrum in the creation of fire implementation guides and other informative documents. And current fire accelerator projects are Argonaut, Da Vinci, and Karen, which is a consumer-mediated exchange standards initiative. So many of you may be familiar with those other projects. Next slide, please. We will also be presenting at the upcoming ONC Interoperability Forum. Many of you have seen Evelyn Gallego present before, and she will be presenting on August 22nd from 9 to 10:30 Eastern in the Renaissance West room, room. And the location and URL and agenda are all listed here. You can find that agenda on the ONC Interoperability Forum webpage. And we will make these materials available to you. And I would like to try to post this in the chat after I stop talking as well, so that you have access to that. And then important schedule updates. As you know, we've gone to bi-weekly meetings until further notice, and we are asking individuals and organizations to submit any food insecurity data elements that they are currently using by Friday, August 30th. And you can send those to gravityproject@emiadvisors.net, or you can go to the Confluence Wiki to get submission details. We are here on August 15th going over food insecurity data sets and value set gaps. And we will be reviewing, Linda will be reviewing the food insecurity data submission stats from the community here in just a moment. And then this slide is the rest of our proposed schedule through October. Next slide, please. And Linda, at this point, if you want to take it away, go right ahead.
Thanks, Lynette. Next slide, Evelyn. What I wanted to do is provide you with the up-to-date list of our submissions. We actually have received several more submissions since our last call 2 weeks ago, so we're up to 11 total submissions, and you can see the numbers of questions, diagnoses, goals, and interventions that have been submitted so far. The bottom part is talking about the ones that we reviewed. We've reviewed 5 of the 11 so far, and we have done updated the dispositions. I showed this similar slide on our last call 2 weeks ago. I also wanted to let you know that we did have 3 submissions where we needed additional information, so we sent emails out to those 3 submitters, and 2 of them have been responding so far. So thank you very much for the prompt response, and we've been taking your information and making appropriate updates to your submission so we can finish the review process. You'll notice here that we have not reviewed any interventions yet or finalized interventions yet from an adjudication standpoint. I believe we talked last time that we needed to take a little more time to think about the organization of interventions and how we are going to approach the review of your submissions. And that's the next section is going to be Sarah DeSilvi, who's going to be taking you through the process, our thought process, and what we came up with in terms of a structure for interventions to get your feedback. So Sarah, do you want to take it over? Oh, I'm sorry, I have one more slide, please. Next slide. Just one more reminder, there is still time, as Lynette said, to submit send a submission till August 30th. This is just a reminder. Here's where the master list is, and that will be published. The latest master list will be published tomorrow. So please take a look at it. If you want to add additional submissions, you still have time to do so in the next 2 weeks. So now it's time for Sarah. Thank you.
Hi, this is Sarah DeSilvi. You might remember me, so I presented at the Food Insecurity Kickoff. I'm one of the 2 subject matter experts along with Donna Bertel from the American Academy of Nutrition and Dietetics. What we are presenting on today is basically some of the background decision work that our interior group has to make as we adjudicate the data. So part of what the labor of this project is not just saying yes or no, but creating the framework by which we build all of the terminology to come, because it just simply has not been done before. So what we're discussing today is some of those decision points that we have and some of those thought processes that we've had. There will be, in the intervention discussion, we're going to talk a little bit about how we're going to query your thoughts on this matter through a straw poll. But our first topic of conversation regards roles. Just a rough overview. So addressing the social determinants takes the shape of the community of concern. We really have tried to not think about any one location as we've thought about how language is used. So activities can and do occur in clinic, agency, and community settings, as you know, by everyone from licensed health providers to willing community members. There's no one way to do this work. So as we consider the documentations, the roles need to encompass this breadth in order to allow for the aim, which is a truly representative and interoperable exchange. Next. So there is an existing taxonomy called the Healthcare Provider Taxonomy Code Set. that includes distinct code for many of the roles we use in healthcare settings, everything from case manager to nurse practitioner, primary care provider, to nutritionist. However, many of the community roles and emerging healthcare roles are not yet in this taxonomy. And this has been evident as we've tried vetted language and things about the roles that we need to work. So it has clearly revealed the need for development in this realm. So we need to develop the encoded terminology for each role used to address the social determinants. However, we have come to the realization that it's simply beyond the scope of the Gravity Project to consider that work in specific. So this is just an honest statement that considering the unique codes for all of the emerging and community roles within this consensus process is beyond the scope of the project at hand, and we're putting forward that it may be appropriate for phase 2. So what this means is we have to accept terminology requests that denote the actions and interventions regarding these roles, because we can't build a thoughtful value set or a thoughtful process without them. So refer to community health worker, refer to social work, refer to care navigator. These kinds of interventions regarding these roles are necessary, and we do accept and have committed to accepting and building language to define those activities. Building the specific codes for each of those roles we're hoping to be in phase 2. Any questions on that admission of limitations? Does that make sense? I don't see anything in the chat, so I think that's hopefully concrete enough. We can have questions at the end as well. So now can we go to next slide? And then the next slide. So the roles discussion is really a segue into the intervention discussion, which has been occupying a great deal of time of the Interior group for the last weeks. As we were receiving submissions, we realized we did not have a set structure to build those submissions off of. And yes, Caroline, I can say that in a little bit. So as we were receiving it, really the California submission from Melissa Cannon that really triggered this, we needed to consider the structure that we built all of the interventions on to make sure there was consistency. In every other setting, there's a structure and pattern of terminology that undergirds standard interventions within the clinical space. So there's terminology for medications, terminology for immunizations, referrals to other providers and specialties. Akin to roles, few of the interventions to address the social determinants fit within these existing terminologies. Thus, we need to build the framework of how we care for social needs within SNOMED CT in order to have consistency across settings, in order to have what I say in this setting mean the same thing as someone in the WIC office, as someone in the designated agency, as someone in the community-based organization, etc. This attempt tries to account for the many settings and roles detailed in the previous slides. Next slide. So within SNOMED CT, all of these activities, these interventions, are within the procedures section. So SNOMED defines procedures as activities performed in the provision of healthcare. This includes not only invasive procedures, but also administration of medicines, imaging, education, therapies, and administrative procedures. Essentially, procedures are all of the concrete activities that clinicians and providers employ to address patient concerns. Next slide. So this is just a general slide with some animations, and so I'm going to ask Evelyn that we click through these kind of one by one. So here are some examples of the interventions presently suggested by the subject matter experts and community members. Those with SNOMED mappings include the respective semantic tags. Each of these raised important questions for care, data tracking, and research that we had to resolve as our internal process group in order to move forward. For example, the underlined section, what are the actions being done to address social determinants of health? Do we know what they all are? For example, what does Meals on Wheels provision assessment mean? That's an existing SNOMED CT code. Does it mean arranging the service? Does it mean educating about the service? Does it mean counseling to determine whether the individual desires the service? There was no consistent definition for that, and that's something that we had to resolve. So next. Again, and we can actually go next twice, so we got both of those lit up. So, and then the next question is, sorry, I'm losing my place here. So the animations are a little tricky. So for each of these, the provision, assessment, and evaluated and educated, we had to figure out what each of these meant, and you'll see that in the next slide. So next, the animation, click it again. I'm sorry, the animations are, so there we go. So, and then another question we had to resolve was, should actual program names, for example, Meals on Wheels and WIC, be included in the concept? Are there parent codes such as home delivered meals that would be better than Meals on Wheels, since several organizations provide meals delivered to a home, and program names can undergo periodic name changes? Next. And then we also had to figure out how to resolve data elements that contained more than one intervention, as in the case of this one, nutritionist, education, guidance, and counseling. How should these be addressed? Should they be parsed out and be individual? Should we have one code for each different topic? Considering all of the actions and programs to address social determinants of health, we basically had to create a structure that will support care, data tracking, and research in multiple settings. So next slide. So sorry for the confusion there. So after much consideration, and we came up with this process and this rough structure that we're hoping to get your feedback on in the straw poll over the next week. It needs to be said that this build included many different concepts in previous work. So in our minds, as we were creating this structure, we included the definitions of the activities themselves. We included existing SNOMED taxonomy. We included a consideration of value sets through Lisa's expertise. We included consideration of programs like meaningful use and like clinical quality measures and patient-centered medical home. So this is the rough intervention framework we created, and the intent then is to apply this rough framework to each of the interventions that have been suggested in the submissions. For example, so referral to. So a referral is a type of order wherein clinicians and providers request services and/or assessment from other professionals and/or programs. So the programs themselves will have individual coding built. For example, WIC or a food bank, or you can even put in the referral here to a role. So for each of these programs and roles, we have the capacity to insert them into this structure to create individual codes for each of these individual activities. Provision of, for the purposes of our project, provision will cover any concrete support that's able to be given to the patient directly at the point of service. So for example, provision of food is an existing SNOMED concept. Food prescription then could be a child of provision of food because you're giving it directly, or in like the ProMedica model, the food packages that are available at the clinic without any kind of vetting or referral might be applicable to this code set. Counseling involves interviewing and applying mental health and behavioral strategies. Education, different from counsel, is delivery of patient education aligned with the goals of care. Assessment includes both the process of provider clinical observation and interpretation and the utilization of assessment tools. In both activities, the aim is to arrive at outcomes that define the status of the patient in order to guide further care. The next one's really important. We decided to use evaluation specifically within the framework of evaluation of eligibility for blank. So evaluation of eligibility for WIC, evaluation of eligibility for SNAP. In some instances, it might even be evaluation of eligibility for food prescription if there's conditions. So evaluation of eligibility is used to mark the activities prior to determination of eligibility. So whatever role it is, whether it's social work, whether it's case management, whether it's a care navigator, it's that activity of evaluation prior to determination of eligibility. And again, this is crucial for federal food assistance programs where you might want a patient to receive SNAP benefits, but they might not qualify. Assistance with, we're utilizing in this instance as non-clinical assistance with the tasks of care. This includes assistance with applications, setting up appointments, etc. And then we've separated out case management and care management because I do know the community discusses these two topics as independent, and we wanted to leave those two activities as separate. I think the only thing I wanted to say last again here is each of these activities contains a whole host of prepositions within SNOMED that are applied, like counseling on, counseling about, counseling for. So what we are going to do as SMEs is do our best to try to match the correct preposition in each of these instances. We may make mistakes, but we're just going to try to take a stab at it and go from there. That is a lot. Any questions at this time I can help with? I do see lots of comments going on here.
Hi, Sarah. This is Lynette. I think I can help facilitate some of these. It sounds like, thank you, Jane, for offering your help. Jane Millar had posted from SNOMED that they are happy to work with us to work through some of these things. Jane, is there anything you wanted to add? You may have to unmute yourself if you want to speak.
Hi, yes, hello. This is Jane Miller, and
hi,
my
Jane.
colleague. Hi, and my colleague Susie Roy, who many of you may know, is on the phone as well. Yeah, I think the earliest we can see this data, the better, and then we can give you feedback and work with you. And I saw the concerns about explosions. I think we're used to explosions and managing them, and I think that your comments about meaningful use, we want the key ones, and then we can work out the ones around the edges, and that's about building towards wider use. So if we can have a dialogue separately after this call, that would be great.
Yeah, I think I don't know if I missed the explosion, Tessa. First of all, thank you so much for that. I do want to say that this is actually our attempt to mitigate a possible explosion, because the whole Gravity project, the intent is to really be careful about what we're building and why we're building, right? So our attempt at creating this taxonomy is really so, at least for what we're asking, there's consistency within it. So we're not muddying the field before we even start.
And I would add, thank you for letting me speak, that this is a major area that we're working with over the next few years. So I think it's really helpful to have this early sight of these requirements. And I know that the organisation.
Oops. Jane, did we lose you?
No, you didn't. I think it just went a bit quieter. That was all.
Okay. All right. Okay. I just wanted to make sure we didn't interrupt you.
No. I think I said what I wanted to say, and as I said, we'll work with you on this. Yeah.
Thank you so very much. Mrs. Lynette, again, this question is from Roberta Severin asking, I'm wondering about the person-specific goals and interventions, which would track a person's progress with the interventions, and can the person be a role?
Can the patient be a role? Is that the question?
Roberta, did you want to add to this?
Yeah.
You may have to unmute yourself.
I don't know. So I think Lisa actually would be a very lovely person to talk about this, because part of what we've been talking about really comes from Lisa Nelson's expertise regarding the building of value sets and the different, and really having to consider functions within care teams as we consider roles within care. So Lisa, can you unmute yourself to answer that question?
There, I was double muted. Okay, thanks. Thanks, Sarah. Yeah, I just posted a couple of things in the chat there, but the notion of a role structurally is handled both in the RIM, some of our earlier structures like CDA uses, as well as in FHIR with a very specific resource that's called provider role. And those roles can be assigned to a person or to an organization. So they're pretty handy notions. And the notion of that role, it's kind of a multidimensional thing, but we also have the notion of a function, which is a little bit different than a role. The role is sort of your role in the healthcare setting, and your function is the function that you play on a person's care team. So you could be a cardiologist. That might be the role that you play in healthcare. But on a person's care team, you might be that person's primary care provider. And there's a common example that we use to try and distinguish the role, your role in healthcare versus your function on somebody's care team. But these are both notions that we have been working on developing over a pretty long period of time. They have expanded over time from including just healthcare professionals in that healthcare provider taxonomy to absorb notions that we ran into when we started thinking about patient-generated documents and more of a consumer orientation. We realized that we needed some roles that came from a value set that was created called personal and legal relationship role type. So we got a whole bunch of new roles that come brother, sister, mother, father, caregiver, neighbor, friend, roommate, kind of a broad set of roles came in when we thought through that. And now we're finding, as Sarah explained, that there are roles that may not be in your traditional healthcare provider taxonomy, and they're not in your personal and legal relationship role type, and we might need to look at expanding some of those roles.
Thanks, Lisa. And if there are further questions about that, you can pose them in the chat, and we can either try to circle back to them.
Roles slash function sounds like an ontological vocabulary thing. And yes, Eric, you are so right. The nuances, sometimes, there's not enough words to go around to really distinguish some of these things. So it is a kind of a funny notion between roles and functions, but we hope the examples help.
And I think just to echo, I think we keep on opening up large vats of understanding that we don't necessarily, that now is not the time to address them, but we discover them as we consider all the things in the current work and our current scope. Mm-hmm. And so as we were saying earlier, I think we realized that we need to consider those kinds of ontologic things regarding social care for social needs, but this is not the time to do that for this work. And so what we really, just to reiterate, what we're hoping to do is include any activity or intervention where that person is required, like referring to the food bank, right, or whatever, but not necessarily considering in depth right now the ontologic, how to code the food bank person as a role individually, and that would be done in later work. Is that safe to say, Lisa?
Mm-hmm. Yeah, I think that's good. I did notice that Roberta is challenging us on a question there. I think I looked back a little bit, Roberta. Sorry, we kind of missed your point there. You had earlier asked about person-specific goals and interventions, and I see that you clarified you're thinking about kind of a plan of care notion there. And I think that we have made some progress. The goals area is one of the areas that has been the least populated in all of the submissions that have come in. this idea of plan of care type thinking and being able to clarify and articulate a particular goal that someone is working to make progress toward, with the idea that we would eventually be able to document progress and perhaps completion of certain goals, so that the care plans would become a mechanism for measuring progress and outcomes. And we definitely are still looking at trying to do that, and you'll see as the goals are identified, we do have some in the master. We hope the community will be thinking across these 4 activities and helping us make sure that we have got the right kind of goals identified so that we can tell if these interventions are having impact.
Yes. Okay, I think I'm unmuted now, am I?
Yes.
Okay, great. I really appreciate that, and that is the direction we're going, because instead of focusing on what needs to happen by the caregiver, we want to have it person-focused. And so if I need to, yes, I need to get educated about the food bank or refer to the food bank if I need to access it, or I need to understand the education, there is then that taking on ownership of what has been happening. I need to know the progress of whether I'm moving forward in those interventions and actually having good outcomes because I'm actually doing something about it, and that's the focus we're on. And so those are the goals and interventions we're creating, and that's, yes, it's a lot of new terminology needed at all kinds of level of specificity, but that is the direction we're going.
Lisa, do you want to speak to the progress towards goal code itself?
Can I ask a question?
Yeah, just go ahead.
Yeah, this is Lucy Johns. This may seem a little abstract on what's already quite a really very interesting abstract discussion, but I just wanted to suggest, when considering roles and functions, from my point of view, the functions that we come up with and are able to code is really the heart of what I would hope this project would contribute. The roles, it seems to me, are endpoint considerations and decisions. And I would hope that part of the contribution of this really cutting-edge discussion is the idea that certain things do need to be thought about and done for patients, but we aren't assuming who is going to do those things within any particular care setting. So we leave that flexible. We don't assume traditional roles. We don't imply that we are binding certain professionals or ancillary sorts of people or whatever from our point of view to certain functions. Certain functions can be allocated in potentially many, many different ways in all sorts of different settings. And reimbursement might actually change depending on who does it. So.
Yeah, sure. Lucy, this is Lisa. I totally agree with what you're saying there, and I would say that you don't have to worry. This is not about reducing the available permutations and combinations. This is about making sure that if you want to be able to do analysis, let's say you wanted to find out, explore who are fulfilling these functions, and you need to be able to capture and do a query to find out what roles within healthcare or other community organizations are actually doing the function of whatever, care navigator or something like that. You want to have enough code so that you could do a query like that and figure that out. So it's not about limiting what roles can do the stuff. It's just about having codes identified so that if you want to document what roles are doing what kind of thing, that you would later be able to do research off from the documentation that's been collected.
Sounds great. Thank you for that clarification.
And Sarah, I did just pull up the goal observation template. If people are really interested in finding out about that, this notion of progress towards goal is something that has been templated in the standards already, and it simply says it's a template that represents a patient's progress toward a goal, and it can describe whether the goal has been achieved or not, and can also describe movement in a patient that a patient is making toward the achievement of a goal. So things like goal is not achieved, or there's no discernible change, or the goal is achieved, or the goal is not achieved but we're making progress towards goal. There's sort of a vocabulary that goes along with it that sort of generally just indicates if you're making progress, not making progress, or have achieved the goal.
Lisa, this is Evelyn. Just to clarify, is that the CCDA or FIRE? Maybe we can put a link here. So I know you have we have defined value set for goals.
Yeah, I'm reading out of consolidated CDA right now.
Okay.
The idea is that some of these profiles are not yet available in FIRE, but once we have the informational patterns down, you can represent the same information in CDA or FIRE. It doesn't matter.
And the reason why I felt like, thank you so much, Lisa, is like in our discussion of interventions, I neglected to include one of the only times, I think it was evaluation, that evaluation was not of eligibility. In our process of discussing interventions, we realized we needed to make space for the evaluation of progress towards goals in our master work as well. So that was one of the outcomes of this conversation. Like lots of conceptual conversation, but your concerns are heard, and we did try to leave space for that question.
Thanks, Sarah. This is Lynette. This was a comment from Matt that flew by earlier, and I wanted to just share it with everyone in case some of the individuals on the call missed it. He's saying there are frequent overlaps between formalized assessments and evaluation of eligibility. This is not an argument for keeping them as separate, but we should keep this in mind as we go forward in case we wanted to automate one function with the other. Did either of you want to comment on that?
Do you want me to try? I think I can try. I don't know unless anybody else wants to pipe in. I think I agree. I think part of the problem is part of the problem and opportunity is that is true in some cases, right? So if we create the separate codes in instances where they're linked, they could be linked together within process build. I hope that answers your question. So if they are linked in the setting and the question and the concern, they could be joined at that time, but we have to build them separate in order to allow for possibilities where they're not.
Yes, and Matt is saying he means that they should be kept separate.
Oh, then we agree. Fantastic.
Yay. Okay. Great minds. Okay, and then this was a question from Ruth Wetta asking Lisa and or Sarah, to what extent will the new Z codes be able to be leveraged by community-based organizations?
Do you want me to try that too, Lisa?
And she's thinking in terms of enhancing interoperability between clinical settings and community settings.
So I think that actually, so some of the questions we are asking are really about allowing for all the possibilities of how this work is done. So I can't necessarily answer that question specifically, dear Ruth. It's nice to hear your voice. I mean, I know you out in the world. But what I'm saying is that I work for our accountable care organization here in Vermont, and so as we cost share with social needs interventions, the ability for CBOs to employ these codes to represent work and cost sharing with ACOs is actually quite important. So I'd say in most of these instances, the capacity is in direct correlation to the project that's being done in the location where it's being done, and we just need to make it possible for that to happen.
Thanks, Sarah. And I don't see any other questions in the chat. Is there any? If you would like to ask a question, you can feel free to speak if you would like to. You will most likely have to unmute yourself.
Is it okay if I say one thing while we wait?
Certainly.
Okay, so again, so this was the if we can go back to the interventions page, just backwards. One slide. So Oh, yeah, so the forward one, that last one. Just want to hover there for a second. So one of the things we were talking about as a group is there'll be some instances where the internal group, the SMEs and the amazing team at EMI and the amazing experts on the project that we're very grateful for, make decisions like saying that the roles conversation is out of scope. In this one, we're not comfortable making that decision. So what we wanted to do is we worked really hard to create the framework, and then Donna Patel of the Academy and I are going to create a straw poll and send that out in quick order just to make sure this seems to represent the needs as they are felt within this amazing collective, right? We don't want to say that this is by rule by fiat. We really want to make sure that as you see them. And so you can expect that to come to an inbox near you over the next days or so. And then if there's not any other questions, we have another topic to raise on secondary diagnoses. Should I segue into that?
You can go right ahead.
Okay, so there's no slide for this because this is kind of hot off the presses. So again, part of what we do in our Wednesday evening, and we actually meet twice a week to try to wrap our heads around this stuff in order to adjudicate it well, is part of what's come up is how to handle primary and secondary diagnoses. So the master list as it stands includes many primary diagnoses that we would say either represent food insecurity or direct other concerns, like there is a insufficient food supply code, and there's a proposal for marginal food security. And then there are all of the codes on there from the Blue Cross Blue Shield and Yale School of Nursing applications for ICD language for food insecurity that we submitted in March to the CDC. But there are also all kinds of other codes that we consider secondary diagnoses because their links to food insecurity is significant in the literature. So there are many codes that are not there that are significantly linked to food insecurity in the literature, the top 10 CDC diseases of concern, and I could go on and on. I mean, there's just so many. And we cited many of them actually in our kickoff slides as literature to support the import of this work. So we have a collective decision to make at some point about whether it's in the scope of this work right now in phase 1 to build the logic of secondary diagnoses in this first initiative. We really don't want to stall the process of submissions, and so what we're proposing is that the SMEs take a best stab at coding things as either primary or secondary diagnoses, and then collect it so that we can keep on submitting prior to our August 30th deadline. And this includes, I know Seattle Children's wanted to assist with developing the secondary diagnoses list because right now it's very robust with the Academy submissions, and I have a bit of work to do there. And then collectively at a future date, so we can get all those in by August 30th, and then collectively at a future date, we can then decide if we are going to pause on secondary diagnoses for right now and not throw them away, but then consider them within future logic and just proceed with primary. Any thoughts on that? Does it sound like a good first step? Seems so.
Silence is agreement. Donna Rugg has a question. Most of these diagnoses would be secondary, wouldn't they? So yes. I think in terms of their response of obesity and malnutrition.
Absolutely. There's very few that would be primary.
So, Sarah, this is Lisa. I was going to jump in just because we have the luxury of extra discussion time today. So
there's
really
actually
nice
one more question, Lisa. This is Lynette. Sorry. Matt is asking if anyone has explored as to whether the National Library of Medicine's MetaThesaurus has already has secondary included. Do you happen to know?
You mean, I think this is in reference to what each of the secondary, there are very...
For existing codes, he's saying,
yes,
for existing codes.
Lisa and I were actually just talking about this earlier. So every single one of the secondary codes that we would consider already exist in ICD and SNOMED in existing terminology. So there is no coding request per se. There's no request for new code or new terminology within the secondary diagnoses. So you're correct, right? So I think, and this was Lisa's point earlier, so she sent me this lovely value set. Lisa, are you in agreement with that?
Yes, absolutely. I think that that's a really important notion and actually there's a very relevant conversation going on about this within HL7 right now to get the much larger standards community on the same page as understanding this characteristic of primary or secondary, and it's muddled in with the notion of principal versus secondary. And we're finding that this is a topic that needs to really be fleshed out because in a clinical setting, it has sort of one connotation. In a billing setting, it has a different connotation. The quality measure people are thinking about it in another way, and in general, we're finding that that this whole group across those three perspectives needs to kind of be on the same page about how we're going to resolve that and code that. There's even distinct thinking about when something is tagged as like a primary or secondary diagnosis at an encounter, does it necessarily imply that there would be that diagnosis added to a person's problem list or not? And so and when it is added to the problem list, it's never added to the problem list as a primary or a secondary thing. It's just a diagnosis on your problem list. And so we're teasing apart the notions of principal, primary, and secondary, really clarifying that so that we use it more consistently across the whole space. And then we are making sure that we can represent the notions separate from each other, but at the same time be able to keep track of the fact that this problem, which may have been a primary diagnosis in your discharge diagnoses, it may just be that diagnosis on your problem list, and it's the same diagnosis. It's not a new one or a different one, but it no longer carries this label of primary or secondary. So it's another one of those what Eric called a terminology ontological kind of thing, but this is pretty much the leading edge of where we are to understand and clarify this stuff.
And one more comment from Nellie saying there are existing official guidelines for ICD-10-CM that define terms like principal diagnosis and secondary diagnosis, and she agrees that we do need to use the terms consistently. Thanks,
yes.
Nellie.
Yes, Nellie, thank you. And there's a big, long thread going on in HL7 right now, and it's going to be talked about at the Atlanta meeting in September. So if you're interested in that and you're going to be at the HL7 meeting, keep your ears to the ground on a joint financial management, vocab, and patient care discussion about this.
Excellent. And I think, Lisa, now you can pose what you were going to bring up. I apologize for interrupting earlier.
Oh, no problem. I think this was the topic area that I was going to dig into, so you guys just beat me to it.
Okay. Are there any other questions or thoughts? Go ahead. I think someone was going to speak.
This is Sarah. I just wanted to make sure that before we got off the phone, folks knew what was coming next based on this presentation today. So I'm going to do a brief summary, and then we can close with more thoughts. So basically, this is a brief presentation on some of the thoughts and decisions that we've had to make as an internal group as we adjudicate submissions, right? And we made some decisions regarding roles that we communicated that we do want to make sure that we're building all interventions that include roles so that we can describe the care we give across all settings, and that the role taxonomy, like building a taxonomy for the social roles to address social needs. That's not our job right now. We'll consider it in the future, right? And then the next thing we discussed is this framework that we are proposing to build interventions around so that we can create this framework and then insert the different programs and roles as appropriate. And I want to be clear just for SNOMED that as SMEs, we are only inserting those programs or roles as they seem appropriate based on our understanding of current process, and that collectively as a community, we can review whether we feel like that is sufficient or not, and that structure that we built for those interventions, we're going to be sending out to the community for a quick straw poll, just so we can keep on moving with our submissions before August 30th. And then the last thing that we mentioned was just that, to keep on moving, we're going to make an attempt to code things as primary or secondary diagnoses, so that we can at least create the structure and finish our vetting and adjudication and create the master list, and then collectively decide on whether to include the secondary diagnoses going forward. Does that make sense for everybody? Sounds the summary. Okay. Okay, now we can do the closing question.
Okay, I will zip through this very quickly, and then we can take any other questions that are left over. Your homework, your mission, shall you choose to accept it, is to submit data elements by domain if you have not already done so, and you can use the Confluence to do that. It just occurred to me also to remind everyone that if you missed the first part of this call, we are on a new Confluence space inside of HL7 because we are officially a FIRE accelerator project now. But if you go to the old Confluence using one of the previous links we've provided, there is a redirect on the page. So you can find us. Don't panic if you're trying to frantically scribble down this URL. You don't need it. You can go to the old Confluence space that you have bookmarked, and you can click on the link that's on the page to take you to our new space. But we are asking for data elements for food insecurity to be submitted by August 30th, which is the Friday at the end of this month. And I think that is all. Let me read this question from Levin asking, has anyone checked out the AIRS taxonomy codes? They're also used in databases for federal HUD reporting in HMIS, which is the Homeless Information Management Systems, and also leverages the ICD-10 codes. Oh, and Lisa has already answered. Thank you, Lisa. Did you want to add anything, Lisa?
I was just going to put the link into something, it's called healthit.gov/ISA. And ONC, in an effort to help coordinate all this interoperability work that's based on standards, a few years back they developed something called the Interoperability Standards Advisory. And they review on an annual basis the readiness and appropriateness for standards that are out there, floating around, developed, maybe used in pockets here and there. And I don't know exactly what their criteria is, but there is a public comment period where you can review and ask for updates and make them aware of new possibilities. So I'm going to put I'll chat the link in the WebEx here, and folks can go and take a look. But there's a whole chapter that is about vocabulary and terminology that's appropriate for use in different areas, and I would suggest that that would be a good channel if that's AIRS taxonomy is something that seems relevant and mature, et cetera, to take it to the ISA.
Thanks, Lisa. And Jane is asking, I understood the interventions framework, straw poll, and primary/secondary diagnosis list as 2 additional next steps. And is this in the next 2 weeks? Jane, I believe I can answer this question. This is Lynette. We will send out that straw poll as soon as possible because we are asking that you all provide feedback on it. This is something that our internal team needs to make a decision on. And to Sarah's point, we don't want to hold up the progress of the entire project. So that stay tuned for that. I would say We will shoot for Monday end of day at the latest. Yes?
Yes, and I think the secondary diagnosis work is actually more, it's like we're trying to spare you. So we, the SMEs, will take on the heavy lifting there. Then that allows things to keep on moving so that we can consider that as a collective at a future date.
Thank you, Sarah. And Lisa just posted the ISA link. It's the very last one in the chat. Thanks, Jane.
And
are there any
Evelyn.
last minute? Oh, go ahead, Evelyn.
Yeah, no, I just wanted to respond to the errors. So this, I think, was one of the comments on the use case. When you are submitting your data elements, I know errors has come up a few times, and it is not currently in the ISA. So it is an opportunity for you all that use it to submit it, and that way it becomes officially viewed by O&C. The other item is, as you're submitting, and if you are using the ERIS taxonomy, our data element submission tool, both the Excel and the web tool, allows you to indicate what your source is or if a reference. So that's also what we're keeping track of. If you are currently using ERIS, that's an opportunity for you to indicate that they've been driven or they exist there, their codes from the ERIS taxonomy.
Thanks, Evelyn. Are there any other questions while we have 3 minutes left? We really appreciate all of your questions and comments. Okay. I will take silence as a sign that we are ready to adjourn. So if you have any further questions, please email us at gravityproject@emiadvisors.net. And in the meantime, check your inboxes. If you do not currently receive emails from us, please go to the wiki, the Confluence space, and join as a member. And we will add you to our distribution list. And in the meantime, we will look for data element submissions from you, and stay tuned for the straw poll. Thank you all. Have a wonderful rest of your afternoon, and we will talk to you in 2 weeks.
Thank you, everyone.
Thank you.